Hi, everybody. Thank you for joining us this evening. Just a few words before we get on to our panelists. I want to thank you all for joining us tonight for Advances in Ovarian Cancer. This webinar concludes our two-part series on women's cancers and is an area of oncology that my father, Dr. Franco Muja, dedicated his life to. My family and many of his colleagues are here tonight, remembering him as the consummate healer who unrelentingly fought cancer together with his patients to ensure the best possible outcomes. All proceeds from this series will go to translational research in women's cancers. I know he would have been very active and an enthusiastic participant tonight, and he is very much missed. I now want to introduce one of our hosts this evening, Valerie Smaldone. Valerie works frequently with the Chemotherapy Foundation as a host and producer for our events, especially our innovation galas, as well as a moderator and women's health advocate. A media personality on radio, TV, and digital, Valerie is a multi-award-winning broadcaster. She is an actress on television, a live event host, and announcer for countless prestigious events, and most recently has become a producer and director. She just completed directing her first feature film, due out this fall. Valerie is a former ovarian cancer patient who formed quite a special bond with her oncologist, my father, who brought Valerie into the Chemotherapy Foundation community. Valerie has interviewed literally thousands of celebrities, entrepreneurs, authors, chefs, scientists, and physicians, and we are very honored to have her co-hosting tonight. And now over to Valerie.
Oh, thank you. Thank you, Paula. It is such an honor to participate in this webinar today, and we're going to be exploring the latest advancements in ovarian cancer research and therapies, and have world-class physicians joining us today. As Paula mentioned, I have been a part of the Chemotherapy Foundation ever since Franco took me to lunch about 7 years ago, or maybe more, and Franco said, I have an idea, and I would like you to be a part of it. And the idea was to produce a big event and host it, which we did, and I never left. And that was the Innovation Gala that we do every year, and one will be coming up later this year as well. A very quick background to my story. Also, Paolo mentioned I did have a bout with ovarian cancer about 21 years ago. I was diagnosed. And for someone as healthy as I was and still is, with no cancer in my family, it was extraordinarily unexpected news. But I was lucky because I was treated at a world-class institution in New York City with an amazing oncologist, Franco. And working with Franco, it was like a partnership, right? We were in this journey together as he listened to my concerns, he addressed them, he went above and beyond to provide information and comfort. And I did well. I continued my checkups and stayed vigilant. But when I was diagnosed, I remembered being a little girl many, many, many years before that, when my uncle's wife was diagnosed with ovarian cancer. She was probably in her late 30s, and there was nothing to be done, nothing. She literally withered away in front of us in the corner in the room. You know, when we would have a gathering, she was sitting there with a blanket, and it was an image that never left me. So that's what I knew about ovarian cancer when I heard I was diagnosed. Now, a lot has changed since the time I was a little girl to when I was diagnosed. And then from that time to where we are today, 21 years later. So this evening, we'll be hearing from two incredible physicians who will share the latest innovation in this area. There's much to get to, and we'd love to hear your questions, by the way. So please feel free to just place them in the chat box and we'll get to them. So now let me introduce my co-host tonight, Dr. William O, who is Chief Medical Science Officer at Semaphore. That's a patient-centered health intelligence company focused on precision medicine. He's also clinical professor of medicine in the Division of Hematology and Medical Oncology at the Tisch Center Institute at Mount Sinai. And very happy to share this news. Dr. O was recently appointed as chair of the Medical Advisory Council for the Chemotherapy Foundation. Welcome, Dr. O. It's great to see you again.
Thank you, Valerie. Thank you for sharing your story. And of course, everyone's connection on this webinar to Franco Muggia, really a giant in the field, such a strong patient advocate and a wonderful humanitarian and doctor. And I think it's really a fitting tribute that we're continuing the Chemotherapy Foundation's mission to really understand cancer, to find better treatments, and to help patients through that journey, because that is exactly what Franco was committed to, both as an academic researcher, but also as one of the best physicians that really ever dedicated his life to defeating this terrible disease. And we're really honored because we have two wonderful speakers who are leaders in the field of ovarian cancer research, who are going to really update us on all the exciting research and treatments that are coming in this field. And I think really the role of genetics, the role of data, and how science really translates to the clinic, because that's something that the Chemotherapy Foundation is really committed to. So I'll hand it back to you, Valerie, to introduce our two speakers. And we will be having a format where each of the speakers, Drs. Blank and Pothuri, will both talk about some of these advances, and we'll have a chance to really interact with them, and certainly invite the audience to do so as well.
Thanks, Dr. O. We'll go to Dr. Stephanie Blank first. And both of these speakers are clinical and also researchers and educators, and helps to take the next generation and give them all this wonderful information and experience that they have garnered over the years. Dr. Stephanie Blank is Director of Gynecologic Oncology at Mount Sinai, as well as a professor at the Icahn School of Medicine at Mount Sinai. Welcome, Dr. Blank. It is great to see you again.
Thank you so much.
You
Shall I start speaking now?
Yeah, you have a
Okay.
presentation that's very interesting, and we'll talk about that as soon as you complete it.
All right. Can you see my presentation? Yes.
Yes.
Okay. Well, it is such an honor to be here today to speak about advances in ovarian cancer. And I'm going to specifically focus on genetics. And I love this topic. It's so exciting. And honestly, when you think about advances in ovarian cancer, you just think about, I'm going to call him Dr. Muggia. I never got to the point where I could call him his first name, but the advances that we're talking about today never would have happened without him. He was always thinking of better things and learning more. And he was also such a great doctor. So, you know, I teared up a little right at putting this talk together. Anyway, let me move on, because we're going to start with some really good news, actually. Ovarian cancer, the incidence of ovarian cancer is going down in our country. Fewer people are dying of ovarian cancer. So the incidence is down over 3% per year, and the deaths are down over 2% per year. And actually, more than half of women with ovarian cancer will live more than 5 years. And that's not the type of statistics you used to hear about years ago. Now, why are people living longer? We have better therapies. Dr. Pothuri is going to speak about some of these. We do a maintenance treatment. We have many more options, and women are also living longer after they've progressed. But why is the incidence down? The incidence is down, first of all, because of oral contraceptives, birth control pills. They decrease the incidence of ovarian cancer, but also for two other reasons. One is risk-reducing surgery, that's removing the tubes and ovaries preventatively, and I'll speak about that momentarily. And another is just about removing the tubes at other times. Say if somebody has a cesarean section, removing the tubes at the same time. And I'm not going to get into the whole reason for that, but it's still, we have a good result here. So why are genetics relevant in this talk about ovarian cancer? Well, genetics play a really big role in ovarian cancer. We can check for what are called germline mutations. Those are mutations you can inherit through blood tests or saliva. And we can also test tumors, ovarian cancer tumors, for mutations. So among women with ovarian cancer, about a quarter will have some sort of BRCA mutation. BRCA is a common mutation in ovarian cancer. And more than 2/3 of these will be in the blood, and the other part are in is in the tumor. And these are important genes involved in DNA because they're involved in DNA repair via a process called homologous recombination. And I'm going to just talk a little bit about that. That's not all, because there was a study that was done over about 400 women with ovarian cancer. They took their blood and they took their tumors and they sequenced them. That means look at the DNA, and they actually found a whole lot more mutations than we previously knew about. We used to just know about the blue and the red here, but BRCA1 and 2, but then we found all these other ones. And when they looked at the tumors, similarly, there were more mutations. And these were all in the homologous recombination area. And when you put this all together, over 30% of women with ovarian cancer show some form of homologous recombination deficiency, and 24% genetic and the rest somatic. And Dr. Pothuri is going to explain why that is so important for treatment, but I'm going to talk about it on the other side. So given the high rate of genetic changes in ovarian cancer, it's recommended that actually all women with ovarian cancer undergo genetic testing. So let's say you're someone with ovarian cancer and genetic testing does show something in the blue or red pie slices there. And why does that matter? Aside from treatment, which we'll hear about momentarily, if you have ovarian cancer and a genetic mutation, it's crucially important for your family to learn about this, because testing your family and people on down the line, this is called cascade testing. And the reason why it's called cascade testing is because it just grows. You test one person, you test more people, and you can really find a lot of people. You have a waterfall here, but also because testing family members with someone with genetic mutation and then acting on the results can literally save lives. So this is just a picture of why identifying people at increased genetic risk for cancer is so important. Let's say, I don't know if you can see my pointer, but let's say you're the person with this person here, and you have a daughter. So this is you have ovarian cancer, you tested positive for BRCA. So why is it important that you undergo genetic testing? Well, if you undergo genetic testing, and your daughter is positive as well, she can undergo screening. She can undergo prevention via birth control pills or surgery that can literally save her life. Or she can be negative, and then she will have a huge amount of relief. She'll have a huge burden off her shoulders. So even in situations where we're walking down the street, what is the scope of this issue in the general population? Not even those whose relatives have ovarian cancer. An estimated 4 million people in the United States have cancer-associated germline mutations, and 1 million people in the US have BRCA1 and 2 mutations. And actually, the vast majority, 80% of people with BRCA1 and 2 mutations are unaware. So how do you identify people most likely to have a mutation? You can look at a multi-generational family history, and I'm not going to go through the small print here, but there are certain things you look for that make you more suspicious. These are the things that I would consider the red flags for hereditary cancer risk. If you have people at young age at diagnosis, different cancers in the same person, somebody has multiple different primary tumors, so say 2 breast cancers on opposite sides, several close blood relatives with the same cancer, and unusual presentation such as breast cancer in a man or Ashkenazi Jewish ancestry. And then who do you test? Your goal is really to have informative testing. So you want to test affected individuals first. You want to test the person with the cancer, because if their test is negative, then testing their first-degree relatives and them being negative doesn't have the same meaning. People ask me a lot about at what age you should test people. I don't think you should test people really before the age of 21, and 25 is fine. You wouldn't want to do it while before somebody really has the ability to understand what it means, and also before it would change anything that you're going to do. And a really important point is, both men and women have the same chances of having BRCA mutations. And even though men don't get, they can get breast cancer, but they don't get ovarian cancer, there are other cancers that they can get, specifically pancreatic and prostate. And then this is really important. If you do have positive results, it's really important to take action. There's really no point in testing if you're not going to act on the results. So when we talk about mutations, some are actionable, meaning mutations with known clinical manifestations and well-outlined cancer screening guidelines, and some are non-actionable, meaning they're a mutation, but we really don't know what to do with it or how to screen for it. So an actionability is constantly changing. This whole field is constantly changing, and action is screening or prevention, and of course, the importance of clinical trials. And I'm just going to close with just saying something I say a lot, which is that genetic testing and acting on results are going to save lives, literally. And this is a great opportunity if you have ovarian cancer to help your family. And it's an exciting time. Thank you.
Thank you, Dr. Blank. Thank you so much. You and I spoke about this maybe 10 years or so ago. And I wonder, in the last decade, what has changed in the form of testing? What is new, and how do you proceed?
Yeah, great question. So actually, so 2013 is 9 years ago. In 2013, the Supreme Court, decided that you couldn't patent a gene, and that was really important because before that, one company had all the rights to testing all the genes. You had to test for one gene at a time, and it took a very long time. But once they were no longer patentable, it really opened the floodgates of a lot of different companies that could offer literally an innumerable number of genes, and through a platform called next generation sequencing. So before it was this called Sanger sequencing, it was very slow, but now they do massive parallel sequencing and you can get so much more information. So it's very exciting that you can get this information. In fact, I generally tell people if they were tested before 2013 that they need to be, it makes sense to be retested. A large number of people that were negative then will find something now. So that's actually really, really good. And we actually just know more about everything. So it's a very exciting thing that we've learned. As you can see, fewer people are getting ovarian cancer because of this knowledge.
Fascinating. I think about crime shows on television because DNA didn't exist in finding criminals before a certain time. And then sometimes there were cells that were available to be tested even after somebody has passed away. Is that possible to do in this case as well?
To test you can actually sometimes test tissue that if it's available. Lots of times, is that what you're asking about? Can you test it? You can't do a blood test, but and actually William may know more about this than I do, but you can test old tissue sometimes.
I mean, Valerie, we've had DNA forever, ever since. It's just that now we know how to really find the clues in it for what actually leads to the risk of cancer, for example. I think if you're asking, like, if a grandmother had died, could we ever find out if she had the gene? And actually, if you saw what Stephanie had shown, the most important people are the ones who are alive, of course, and you can actually trace backwards. This is different from finding, let's say, the criminal who might have committed a crime 20 years ago, because the people who matter are the people who are alive. That's exactly what Stephanie was saying about cascade testing. We can actually, once you find somebody with the gene who's alive, you can actually go backwards to the cousins and the parents and the relatives and the children. So I want to just emphasize this, and Stephanie, because it was a really great overview. I think people are hearing more and more about testing, but one thing that people still get confused about, including doctors sometimes, is the difference between germline. You talked about germline and somatic, and I want you to reemphasize the question of what's inherited or germline and what's somatic. Just because people don't always, when they hear the word gene, they assume it's something they inherited, and that's obviously very important in ovarian cancer. But there are some people who get cancer with mutations in their tumors that did not inherit it. Can you just clarify that a little bit more?
Well, you said it very clearly, actually, I think, but so everyone has genes. Actually, everyone has a BRCA1 and 2 gene. I recently spoke to a doctor that was saying, well, this person has a BRCA1 gene. And anyway, so that's actually very important. But you can inherit, just the way you can inherit a hair color, an eye color, you can inherit a mutation in let's just say the BRCA1 gene. And that means that you're born with it. And the reason why that's important is it makes you, it's usually several things that happen before something turns to cancer, and you sort of already started out with one of those things. So sometimes the ones that happen in the tumor just happen locally. So you weren't born with it. The other cells in your body might not have it, but something happened in your tumor where those cells were growing to develop that mutation.
Right. And there is a question in the chat. You brought up birth control as a reason why there's less ovarian cancer. Can you clarify why birth control would lead to less ovarian cancer?
Yeah, I mean, it's not 100% clear, but we do think it's because it cuts down on ovulation. So Other things that have people ovulating less, such as, for example, having many children, that's preventative against ovarian cancer, and birth control pills do the same thing. That your ovaries aren't constantly, you know, kind of getting damaged or regenerating, and that's what the thought is with that.
I saw an article today that in the New York Times that girls are going into puberty faster. Do you think that, I mean, I know it's indirect, but does that mean that if they're ovulating more and earlier, that we might, that might actually increase the risk of developing ovarian cancer in the future?
Well, I'll answer that in a couple different ways. Obesity may, which is probably the reason why people are ovulating sooner. I'd like to say no, because we're going to know so much about genetics that we'll be able to prevent it. That's what I would really like to say. But I think it's not like everyone has, you know, if you start earlier, you end earlier. So certainly somebody that has a much longer amount of time that they're ovulating is going to be at an increased risk for cancer.
Dr. Blank, you mentioned the Ashkenazi Jewish population was at risk, but there are other clusters around the world as well, aren't there? I recently learned about Sicily, for example. What other areas should we be thinking about?
Well, it's a lot of areas where people were kind of mostly with other people. So, I mean, French Canada is a big area. There's you know, Iceland there. I'm going to forget some. Where else can I think of? I mean, there's some in China, there's some in Africa, all different areas, but usually where it's a small, more insular community. You know, one thing we've learned is that we're really not that good in figuring out who's going to get a mutation. Most of the people that have these mutations don't have any family history or anything, nothing at all that makes us think. So it just, you know, some people talk about testing everyone, and I don't know if we have the time to get into that, but there's some sense to that.
Let's talk about that. We do have a moment. Because that's an interesting idea.
Yeah.
Why not test the entire population to see who's at risk?
Well, I mean, I'm not, you know, cost, stress, you know, a whole lot of things can go, you know, can go along with that. But, you know, Mary Claire King, who is one of the founders of the Genes, is an advocate. She thinks everyone should have testing at age 30 because we can't figure out who, and that ovarian cancer is completely preventable if you find that out. And I kind of like that, because I really don't think we're very good at predicting who's going to have a mutation. The people that I'm so sure are going to have a mutation never have a mutation. Really? And then the ones that I don't think do.
Well, you know, the family history, doctors take family histories, and family histories are notoriously unreliable. Think about it. Think about your own family or people that you know. People don't talk about what their grandmother died of. People who think they're related or are not sometimes related genetically. And many times, like, somebody might be adopted or not know their family history at all. And so when they've done studies of just testing everybody who walks into a cancer clinic, about half of the cancers are discovered by, or the cancer risks are discovered by the family history or other guidelines. The other half are completely random. And as you saw in Steph and in Dr. Blank's presentation, there are huge numbers of patients who don't know they carry these genes. And the question is it worth it to try to discover that in order to save their lives? And that is a debate we're going through. You know, 20, 25 years ago, people were very worried about doing genetic testing because they were worried if they would get discriminated for insurance and other issues like that. I think now we've come to a place where people are sending their DNA to a recreational lab to find out if their favorite color is blue or pink. You know, it's like and so people are feeling more comfortable with this idea. And why not use it for something that can lead to basically a prevention or a cure of a very high risk of disease? And of course, you know, maybe Angelina Jolie probably brought this to the front fore in a very positive way in today's society. Mm-hmm.
Yeah, I just want to make a couple of points on this because it's so interesting. You know, I think that, you know, also many people are getting the, tests like 23andMe, which are highly, inaccurate and they get falsely reassured. So there's already this sense that people want to know, you know, and it would be nice to offer them a more comprehensive and scientifically valid test to really reassure them. And I think another point is that, you know, while, and Dr. Blank pointed out how important cascade testing is, but there's so many challenges to that. So, you know, family members don't always talk to their, you know, relatives. They don't always share this information. And, you know, you know, we've had kind of a facilitated cascade testing program that we're running, and we found that it's not successful. So I think there, you know, I think there's you know, there really needs to be more thought to this idea, and I agree with, you know, Dr. Blank and you that there really is we really do need to carefully consider more broad testing.
Well,
So,
go ahead,
oh,
Dr.
sorry, I was just going to read the question from Leslie so that Stephanie can address it, which is, you say that ovarian cancer is completely preventable. Does that imply that all ovarian cancer patients are BRCA positive? You said 25% are positive, so please explain.
Thank you, Leslie. I'm glad you asked that because I clearly did not explain this very clearly. And actually, I did overstate. I guess all genetic related ovarian cancer could be prevented, you know, potentially. It's not that depending on when people were tested, but yes, about 25% are positive BRCA, a little bit less than that.
So that population.
Yeah, please let me know if that was not clear and I'll type it out.
Thank you, Dr. Blank. And before I let you go, and of course we can continue this conversation, it's kind of a nice flow happening here. Is it ever too late to test somebody? Is there an age, do you age out?
I really don't think so. I mean, I think there are some people that think, well, I made it to 70 and I didn't get any cancer, so I don't have anything. But I mean, people are living longer. You can get these cancers very late, and specifically ovarian cancer it's not a cancer you want to get. I'm sorry, we're talking about all these advances and things are much better, but if you can prevent it, it's definitely worth doing. So I don't think so.
Very interesting. Thank you so much. But obviously we're going to continue to talk with you, but I'd like to now introduce Dr. Bhavana Pothuri, Professor of Obstetrics and Professor of Gynecology at NYU Grossman School of Medicine, Director of Gynecologic Oncology, Clinical Trials, NYU Langone Health. Dr. Pothuri, thank you for joining us as well, and thank you for your previous comment. You have another presentation to share with us.
I do. Let me. Can you see this?
Yes.
Okay. Perfect. All right. So first of all, I just want to say I am honored to be here. And Dr. Mujia is, you know, just an amazing human being, individual, mentor, physician. His passion for learning and really taking that learning and trying to improve others' lives, like, really resonates with me and lives on in me. And that's, you know, what drives me. And so I am just so gracious to have been trained by him and mentored by him. And I'm sure he's going to be smiling as he hears all the great developments that are occurring in the field of ovarian cancer. So with that, these are my disclosures. I think it's important to really for everyone to see. But I think it's, you know, this is an amazing time, really, in the development of new therapies for ovarian cancer. And, you know, I think this slide says it all. From 2014 to 2020, there have been 14 new FDA approvals in ovarian cancer. And that's more in the last 6 years than there have been in the prior 60 years combined. So really, we are making progress in ovarian cancer. And the majority of these approvals you can see here are PARP inhibitors, which is what one of the areas that I'm going to really focus on. And PARP inhibitors are essentially, let me just keep moving. Oh, okay. So PARP inhibitors are targeted therapies, and they target the DNA damage repair proteins called PARP proteins, PARP enzymes. And as Dr. Blank pointed out, when patients have an abnormality in either the BRCA genes or one of the other genes that makes them what we call homologous recombination deficient, they're more likely to respond to PARP inhibitors. And here, these are the FDA approved PARP inhibitors and the different indications. And PARP inhibitors are now approved in multiple lines in ovarian cancer. So they're approved in the frontline setting for maintenance therapy. They're also approved in the recurrent setting. And platinum sensitive in the platinum sensitive setting. And then they're also approved as treatment. And those are mostly in BRCA carriers, either in the germline or in the tumor. And that's what, Dr. Blank was talking about, that differentiation, whether it's in the blood or in the tumor. But it's also, it's now indicated for patients who have that, designation of HRD, so for treatment. So we talked a little bit about the rationale, and as you know, Dr. Blank talked about all the genes that can lead to being HR deficient, the BRCA1, the BRCA2, and the other genes that can be involved. But there are also other reasons, and overall about 50% of patients with your most common type of ovarian cancer, the high-grade serous, have tumors that are homologous recombination deficient. And then these are the different PARP inhibitors that are now approved in ovarian cancer. We have 3: olaparib, niraparib, and rucaparib. And I don't want to get into all the nitty gritty, but these are all the different indications. And then I'm actually going to just focus a little bit and kind of just give you a glimpse of, how these agents have really made an impact in the frontline maintenance setting. So after you have your surgery and your chemotherapy, PARP inhibitors are now standardly utilized in the frontline maintenance therapy. And why is this so important? While patients really with advanced ovarian cancer respond really well to chemotherapy, and the chemotherapy is highly effective, once they when time passes, we see that in about between 8 and 12 months, and this one study in the orange here is really a little bit longer because that's just in BRCA carriers. But around that time frame, the tumor relapses or comes back. And so it's really important to find new therapies that can really prolong that time where patients are free of disease. So this was one of the early trials that Dr. Katie Moore led, and it's a very important pivotal trial called SOLO-1 that was published in the New England Journal. And it looked at patients who had a BRCA mutation, so either a BRCA1 or 2 mutation, either in the blood, germline, or in the tumor. And basically they were, like all large studies, they were randomized, or essentially a flip of a coin, to either get the medication olaparib or a placebo, which is essentially a sugar pill. And what we found with that was, here on the top line here is the olaparib, and then the bottom line here is the sugar pill or placebo. And we found at all time points that we see here that patients on the olaparib had a longer time that they were free of disease. And that's essentially what these curves show us. And this is how we assess the value of these medications. And then I like this slide because it really shows us that even if you look here, 60 months, so even at 60 months, and patients actually stopped the treatment after 2 years at 24 months. So even after they stopped the treatment, almost 50% still were free of disease. So this data is really encouraging and really shows us that there may be, a really long lasting benefit to PARP inhibitors, and that we may even be curing people in this setting. Obviously, we don't have that even longer term overall survival is what we call it data, but that's what this is kind of, hinting at. So really exciting to kind of see this information. And then the next trial is called the PRIMA trial. And this is a trial that I was involved in. And it really looked at another PARP inhibitor called niraparib. And what this trial did was it went beyond just patients with a BRCA1 or 2 mutation, and it included all patients with ovarian cancer. And it kind of did the same thing. It, randomized that flip of the coin to either niraparib or the placebo, which is the sugar pill. And in this study, they were treated for 3 years. And then again, when you look at these, these curves, these Kaplan-Meier curves, we call them, you can see here, the top, the green is the niraparib, and then the red on the bottom is the placebo. And you can see here, the curves really stay separated. And, at all these different, except for in the very beginning, the first few months, you can see here, these curves stay separated. And at all these time points, patients who received the drug, the niraparib drug, remained free of disease longer. And so this first curve is in that group that had the HRD, which is, the patients we would expect to really benefit from a PARP inhibitor. So, and the way this trial was designed was if this looked good, then they would go ahead and look at it in the entire study group. And that's what this shows. And in the entire study group as well, again, you see that similar separation of curves, although the benefit may not be as great, but there was still benefit. And the top is the niraparib and the bottom is the placebo. And then I want to go on to Paula 1, which is a trial, also a large, phase 3 trial. And this looked at the combination of olaparib, that was the first drug that I talked about, but it adds another medication called bevacizumab, which is involved in targeting the blood vessels. And this trial looked at again, a randomization in patients with ovarian cancer after they finished all their chemotherapy. And as maintenance, they would either get olaparib and bevacizumab, or they would get placebo, again, a sugar pill with the bevacizumab. And this continued for 2 years of the PARP inhibitor and 15 months of the bevacizumab. And again, this trial also showed this benefit, although that seems to kind of level off after some time. But clearly there is a benefit with the combination of olaparib and the bevacizumab compared to the placebo and the bevacizumab. And this is just, where we've come, and the guidelines have changed. And, ASCO, which is one of our very premier societies, is recommending that we offer PARP inhibitors to our patients in the first line. So olaparib for those that have BRCA mutations, and then niraparib to all patients, regardless of mutations. And then the combination to those that have what we call HRD. And then, I think when we talk about, since we're talking about this idea of maintenance treatment and, giving medication to keep the cancer from recurring, I think it's really important to talk about these 2 trials, which were also very important pivotal trials. The first one is GOG 218, which was done in the United States. And then this one was ICON 7, which was a European trial. Both of these were really positive trials. They were published in the New England Journal, and really kind of highlighting that, bevacizumab also does have a role in the maintenance treatment. And, to kind of put all of this, together, right? These are all the studies that look at maintenance therapy in the front line. And, you can see here that, all of the trials really show a benefit to utilizing either bevacizumab or a PARP inhibitor in the maintenance study. And, I don't want to get bogged down with details, but the way we look at that is what we call the hazard ratio. So this kind of slide is just to show you like how we've kind of evolved the way we treat, newly diagnosed advanced epithelial ovarian cancer in 2022. Our first big decision is, do we give, neoadjuvant chemotherapy, or do we go ahead and do a debulking surgery? And then after that decision, we then decide, when we're giving our chemo, do we add bevacizumab or not? And then depending on if we've added bevacizumab or not, it kind of helps us in terms of the, maintenance therapy that we're going to choose after they finished. And usually, if they haven't had bevacizumab and they have a BRCA mutation, I think I've shown you the importance of adding a PARP inhibitor in the maintenance setting. It's considered standard of care to have a PARP inhibitor, especially if you have a BRCA mutation. And I would go as far as to say, or if you're HRD positive. And then, if you are HRD negative, some people do observe, do consider observation, given that the benefit with the PARP inhibitor is not as great as it is in the patients who have BRCA mutations or HRD. And then if you've started the bevacizumab already during the chemotherapy phase, then you would consider, continue it. And that's mainly because in the studies that I'd shown you about bevacizumab, we learned that, the benefit of bevacizumab was really when you gave it in the maintenance setting, not just with the chemotherapy. And so you would continue it. And then if they were HRD positive, you would add a PARP inhibitor. And then if they weren't, then you could just continue with the bevacizumab. But this kind of one slide kind of shows how we've incorporated all of those studies in the way we care for our patients. And then I want to just kind of, touch upon like where next. So, there have been there have been 2 trials that we've completed that have just utilized either a checkpoint inhibitor or immunotherapy, or immunotherapy and bevacizumab. And those 2 trials so far have been negative. But there are other trials that we are still awaiting the data on. And all of these trials have now completed, except for the last one, which is Flora. All of these 4 have really completed accrual. And so we're eagerly awaiting the data to see if combinations of PARP inhibitor with immunotherapy and bevacizumab, if there's any role for anything more than what we've already kind of established as important in the treatment of ovarian cancer in the maintenance setting. I'm going to kind of switch gears a little bit now. If we've talked about how, the treatment of GYN cancer is becoming more and more individualized, and how I've just shown you how PARP inhibitors are a targeted therapy, how they work better in BRCA and HRD patients. And then, we didn't really get into this, but, there is information, and there are a small percentage of ovarian cancers that do have what we call MSI, or mismatch repair deficiency. And this is a very important biomarker that predicts response to immunotherapy or checkpoint inhibitors. And they are actually, if you looked at my very first slide where I have approvals, they're actually approved for patients who have MSI high or MMRD, and for patients who have high tumor mutation burden. That's another kind of biomarker for response. So this is how, our treatment is getting more and more targeted. And so now antibody drug conjugates are really the next frontier in terms of personalized therapy, because they allow us to target very specific tumor antigens, meaning little markers that sit on top of the tumor. And then it allows us to deliver. So we use an antibody, and and that allows us to deliver. It kind of binds to that little marker on the tumor cell, and then it allows us to deliver chemotherapy directly into the tumor. And so it's a new way of delivering our cytotoxic treatments. And here, this is what I was trying to explain, but a picture is always better. So this is what an antibody drug conjugate really consists of. There's like 3 different parts. This, some of you are probably very familiar with this Y-shaped, configuration. That's very classic for an antibody. And then to the antibody, there's these yellow things are little linkers. And then the red balls are the cytotoxic drug, or we call cytotoxic warhead sometimes. And then the next slide actually shows how this all works. So you see how this little Y-shaped antibody, it identifies this light blue, which is the little marker on the tumor cells. It binds, it then gets internalized. And then once it gets internalized, it then gets broken down, and then it releases the yellow, which is the active drug, which can then, fight the tumor cell. And so, in this process, targets are really important, right? Because that's how the antibody identifies the tumor. So you want to find a target that has high expression on tumor cells, but not on the normal cells, right? Because you want to avoid causing toxicity to normal cells. And ideally, the target should be on the outside or the surface of the cell so that the antibody drug conjugate can find them. And then they should be able to be easily internalized and transported into the cell. And you can think of it kind of like a Trojan horse, where you kind of trick the cancer cell, into thinking that this is, to get in. And so that's a simple way to kind of think about it. And so I'm not going to bore you with all the details, but this one study, Soraya, which was recently presented at our SGO annual meeting a couple of months ago, actually presented data from this trial, and it looked at this new drug called mirvetuximab, and and what that binds to is a specific receptor called FR alpha in platinum-resistant ovarian cancer. And you all may have heard that platinum-resistant ovarian cancer is a real unmet need. It's once a patient develops ovarian cancer that's resistant to platinum, their likelihood of responding to other therapies are very low. So it's really important we find new therapies in this area. And this study looked just at that. And when they looked at it, they found that the response rate was really quite good. It was 32%. And, typically in these platinum resistant groups, we find it about 10%. So this is a real win in terms of identifying a new therapy for these patients. And then this is another study that was also presented. This was an early phase. This was a 1B. That was actually a phase 3, a single arm phase 3 study that was presented, the Soraya. But this is a 1B, so an earlier phase. But again, it gives us also in the platinum resistant group, and this target is a NaPi2b. It's a different antibody drug conjugate called UpRi. And again, you can see that, they found a response rate, in the 30 to 40% range, which is quite good. And then, I kind of want to end on, what's coming. And so there is, they are looking at this antibody drug conjugate UpRi and in a platinum resistant setting. And this trial is a phase 2 trial. And the idea is really to try to get this FDA approved with this data. So obviously, it's really exciting to be in this field at this time. You've seen kind of like the evolution of how we got, PARP inhibitors to our patients. We're now on the forefront of getting mirvetuximab. Hopefully, fingers crossed, that will get approved. And then hopefully Uplift will give us another antibody drug conjugate at our fingertips for this very important patient population that we're trying to treat. And there's lots of other, obviously that immunotherapy question in the frontline setting is still yet to be answered. There are other really critically important questions. What next after PARP inhibitors? Are we, can we use PARP after PARP inhibitors? And there was some data that was presented at the ESMO meeting this past year called the ARAO study that looked at utilizing PARP inhibitors again. And there seems to be benefit with that. But, that data we can't really apply to the current situation because now we've really moved PARP inhibitors into the frontline setting. And a lot of those patients really received PARP in the, second or more line setting. So there's a lot of interesting questions, a lot of new therapies, and really it's an exciting time to be in the ovarian cancer space. You may also hear about there's a new tumor treating fields, which really is looking at utilizing these electromagnetic fields to see if we can also improve the treatment of ovarian cancer. And there's some phase 3 data that we're awaiting as well. There's some interesting like immunovascular modulators that are also being studied. So as I said, lots in the pipeline, and really I'm just excited to be in this space and really help our patients.
Wow, that's very encouraging news. It's very interesting what you outlined. It made me think about, as you said, years ago, there were very few drugs. And the therapies at the time were to sort of blast the patient, the whole body, and people got quite sick. It was not a pretty situation. I wonder about these new specific drugs that have come out. How are patients tolerating them? Is it better for them overall?
Yeah, Valerie, such a great question. And typically, I don't ever talk about drugs without putting in like their adverse effects. And I actually just took them out before thinking it would be too much. So I'm glad you asked, because I think it's such an important thing, right? It's not just bringing new medicines, but like how are patients tolerating them? How are we affecting their quality of life? I mean, these questions are so critical. And so I think, let's talk about PARP inhibitors first, because they're both very different. So PARP inhibitors as a class have very similar side effects. And the most common ones are really nausea, GI. So you can kind of lump them together: GI, nausea, vomiting, constipation, diarrhea. The GI, especially the nausea, vomiting, tend to get better with time. So, I think it's really important to just, get patients through that first 1 to 2 months, and then just also so they understand that it will get better. So they know what's coming. And then the other, really, I think, important side effect is fatigue, which really can affect patients' quality of life. So I think it's really important that they understand that. And so promoting like exercise, to combat fatigue. Recently I learned that ginseng can also improve the energy and people feeling better. And I've actually also, like, some of my patients, I've actually needed to use some psychostimulants on, and they have it like, and they say, oh, I have to be like, I really have to be on, I'm presenting something, or I have to like go to an important event and I just don't want to feel like I'm blah without energy. And they've used it, and it's helped them through it. And I think it's really important to like think about all these things, right? Because patients are going to be on this for 2 to 3 years. That's a long time, right? And we have to make sure that they can do the things that are meaningful to them. So, so I think, you like hit it spot on when you asked me, what are the toxicities? So thank you for asking that.
My favorite psychostimulant is caffeine. That's what I use.
Yeah, I agree.
Good for doctors, it's good for patients, right? It
Yeah.
can help.
Yeah. Oh, and
So
the other thing I wanted to also, I think is another important thing is it also does affect your blood count. So, we have to just really monitor their like hemoglobin and make sure they're not getting anemic. And then, if patients are on it a really long time, and this is less important in the frontline setting, but like if you're using it more in the recurrent setting, the rates of like MDS, which is a serious blood disorder, increase. So that's something also that, people need to be aware of.
So, thank you for that really great overview. If I could summarize where this field is going, there's two things that I noticed, right? The first is that, Stephanie's talk about genetics now leads to therapeutic consequences. So understanding the biology leads you to develop drugs that actually target that biology. The second point is ADCs, this antibody drug conjugates that you talked about. People will hear more and more about it, and obviously in ovarian cancer, but it's actually it's a drug delivery system. And so you'll see more and more drugs delivered that way across all cancers. It's very encouraging because it's like a smart bomb, right? That's the idea. It's a smart bomb or a Trojan horse. I love these analogies. And it's a way to target the cancer because certain drugs, as we know, chemo is the most classic example. People get really tired because it affects other organs like your hair or your blood cells. And the more we can actually just target the cancer cell and not the rest of the body, the better patients will feel. And the third thing I just want to comment on about your excellent overview, Dr. Pothuri, is that obviously we have a long way to go. Like for a patient, 30% response doesn't sound really good. I know I've talked to a doctor's audience and I'll say, this is amazing, but they'll say, well, that means 60, 70% didn't respond. But I think people always have to remember that we're building on, it's like a stepwise approach. The eureka moments in medicine, unfortunately, they don't come very often. Immunotherapy is one of them. And I want to ask you that question about immunotherapy in a second, because everyone asks us. You highlighted it, but how are we going to build on immunotherapy in ovarian cancer? But just as a reminder, 30% is very big because the usual response after you fail platinum is so low. So many drugs don't work. So I just wanted to emphasize that. But can you just talk a little bit about immunotherapy, because everybody wants to know about immunotherapy. How is it going to get better for ovarian cancer?
Yeah, so I think one, we need to see what these combination trials show in the front line. They're all accrued, and I don't think we're going to do a whole lot of investigation in immunotherapy till we get this data, honestly. But I also think that, it really, we need to find the right combination in ovarian cancer. And it's not going to be single agent checkpoint inhibitor. That's not going to work. So there is some data with combination therapy with Nivo and Ipi, a CTLA-4, but I think we need to move beyond that. And there are some, bispecifics that are coming with less toxicity, and other novel combinations, where we can really turn that, cold tumor, which we think ovarian cancer is, into a hot tumor. So we're not there yet, but that is our goal.
Thank you.
You mentioned something, and this is a layperson asking the question. Obviously, you said the tumor is suppressed for a period of time, and then it rises up again, and that's the recurrence of the cancer. I mean, I would imagine for all scientists and doctors and researchers, the goal is to stop that tumor from reoccurring. How far away from that happening?
Yeah, no, that's a great question. And that's why we're so excited about the Solo 1 data, right? Because I showed you that, even after stopping the drug, it seems to be keeping the cancer away. So, PARP inhibitors may be one drug, especially in BRCA carriers, that we might be achieving that. Ultimately, you're absolutely right, Valerie. We want to do that in every patient, regardless of BRCA status, but we're not there yet. And that is our goal. And, I don't know if it's going to happen in my lifetime, and I would love if that would happen in my lifetime, but that is certainly our goal.
Well, when you
Yep.
think about, how AIDS has changed, right? How in the beginning it was such a deadly diagnosis, and now people are living long lives, maintaining their health through proper drugs and proper care of their lives. So, I mean, if we can just live long, I don't like that statistic, a 5-year statistic that was given to me too. I had a very good chance to live 5 years, but I'm like, why are we even talking 5 years? That's not a long
Right.
time.
That's not the right statistic anymore for ovarian
It's
cancer.
not,
anyway.
because people are living much longer.
Yeah,
Right.
you're right.
Yeah,
It's
we
a
don't
bad
even talk about.
statistic.
Yeah, we don't even talk about that anymore. And then, the other point too is there's also drugs like checkpoint inhibitors in certain subset, like immunotherapy, where we are curing patients, right? So if your ovarian cancer was mismatch repair deficient, or, has a high tumor mutation burden, these are tumors that, I have seen cures in. So, so I think we just need to we need to continue to subset. We need to not treat ovarian cancers as one. We need to really find targeted therapies that are going to work for each tumor. And that work is happening.
I think this is a really good question for Dr. Blank, I think from Leslie, which is it correct to say that those tumors connected to or caused by BRCA mutations are actually more treatable?
Yeah, that's a great question. So BRCA mutations are associated with a better prognosis because, as you say, they're more treatable. We used to just know that they were more sensitive to platinums, but now we also have PARP. So we not only were they more treatable by our sort of older fashioned type treatment, but now we have a new treatment that can actually make them do even better. So it's a very good prognostic sign, especially BRCA2. But everything is.
Yeah, there's an analogy in breast cancer where if you carried an alteration in HER2, or you made too much of this protein called HER2, your prognosis was worse until a drug was developed that actually turned that tumor, that specific HER2 expressing tumor, into a better responding cancer. So sometimes you can turn a negative into a positive, and that's really why studying the tumor, understanding what's different and unique about an ovarian cancer in one woman versus another makes such a big difference in the long-term outcomes. So I think, there's been really wonderful conversation, and I thought I would just ask you both to, maybe tell us what you think the future is for ovarian cancer. What do you think is going to be the most important thing in the next few years in ovarian cancer? And then I'll leave it to Valerie and Paula to close us out. Stephanie?
Yeah, I think we're going to learn more about individualizing care, targeted therapies like Dr. Pothuri spoke about. I think different patients should be treated in different ways. And I do hope, and we have seen it, even people who don't. The goal is not to treat recurrent disease. The goal is to have people never recur. So we have to keep looking. I think an important thing, maybe we can de-escalate treatment in people that don't need. Sometimes we overtreat people. And I also think a lot of these newer drugs have fewer side effects than chemotherapy. So we're placing a lot more importance on what we call patient-reported outcomes, sort of how patients are feeling on drugs. And I think people, ultimately, I'd like there to be no cancer, of course, but if people are going to have it, I think they are living longer and better. And I would like that to continue. I think you said something about 30, you kind of like get through one and then there's another discovery and you get on that one and that one. So I think that we've really seen so many more options for these patients. And that's what's really exciting. And also options that are tolerable and people can be on long term. So I'm very excited.
Dr. Pothuri?
Yeah, no, I would agree with all of that. And I'm just excited that women with ovarian cancer are living longer. I'm excited that we are seeing less ovarian cancer. And I'm excited that we have all these new therapies to offer them. And I'm hopeful that we will have more. And as Valerie pointed out, I hope that we can cure it. Yeah.
And early diagnosis.
And
Oh,
I
yes.
also envision, universal genetic testing, honestly. I think it's, it's only a matter of time.
I love the optimism and all the great information that you have presented to us. We truly appreciate it. And I want to thank Dr. Blank, Dr. Pothuri, Dr. O. What a great co-host, Dr. O. I so enjoyed working with you.
Have you done television before?
Yeah.
And to Paula and to Wizard, thank you so much. Also, I'd like to recognize our sponsors, Betta Claire, Ronald and Joan David Foundation, Alfred Goldstein, Nancy and Stephen Jaffe, David and Penny Klein, Eric and Lori Richter, Michael Rosenberg and PIM Brands, Suzanne Noble, Barry Lane, Dottie Payson, George and Janie Shilka. And I should also mention this is going to be available on the website, which is great for those who missed it. And I know a lot of people will be checking this out. You can follow us on all social media platforms, Twitter, Facebook, Instagram, to learn about new advancements in cancer research and more programs to come from the Chemotherapy Foundation. And although it is 6 months away, put it on your calendar. November 10th is our upcoming gala. Time to plan. I think it's fine to do. This was a spirited and wonderful conversation. And I once hosted something years ago called The Good News About Cancer, because I wanted to put forth the good news, which you certainly did tonight. Thank you all so very much. And thank you for having me. I appreciate it.
I just want to chime in very quickly. Thank you, everybody. This was just, it was fascinating. It was perfect. Thank you so much.
Bye, everybody. Thank you.
I like the
I
cat.
thank you.
Bye-bye.